Good morning, good day, good afternoon, good evening. I know we'll all be listening from different time zones, but let me start by thanking the Global Listening Center for this opportunity to talk about my work. And what I focus on when I go about teaching effective listening is to spend a lot of time teaching healthcare professionals what it is not, rather, what it is. And so that is how I was asked these questions. And that is exactly what I will address, even though it seems a little counterintuitive. I'm going to explain it today. The other thing I was asked about is why do I think this method of teaching became popular with commercial organizations like hospitals and pharmaceutical companies and biotech and so forth? And I'll be able to get to that towards the end. But to answer these questions, I'm going to share with you some examples of training materials I've developed over 3 decades of working with healthcare and pharma organizations and medical associations. In my 20s, I was trained as a humanistic psychotherapist in the tradition of Carl Rogers, and more on that later if there's time, because he's considered to be the father of active listening theory. In my experience, there's just an enduring, ongoing, nonstop demand to learn active listening skills in patient-centered settings. So I will be commenting on how I've carried my methodology across these 3 decades. All the illustrations I'm going to give you here are from programs I designed and delivered for the variety of settings. And if time allows, I'm going to share a little bit more about my educational experiential pathway that led me to this. But first, a word. I almost always start my training sessions with healthcare professionals by presenting a real-life case study, something that's very rich with dialogue. And the goal here is to bring the audience immediately into a world that they recognize. I was very lucky that I collected over 1,000 of these case studies during the days in the United States where the privacy medical laws were not as strict as they are today. And I was allowed to listen and observe in a wide variety of settings as I worked with clients. So here's an example that has worked well to kick off training sessions in active listening. So let me explain your paperwork and we'll get you on your way, says the provider. Oh no, I just remember I forgot to ask that doctor for a chiropractor referral. Why don't you write me up a little note? Well, why do you think I can do that? Well, I know he'd do it for me. He always helps me out. Well, that may be so, but we got to even find out if your insurance is going to cover it first. Well, I would have asked if I'd remembered, but he was rushing me. I know he'd do it for me. Well, you should talk to him about this. If you wait till the end of the day, I might be able to squeeze you back in to see him. I've already been here forever. Just help me out this one time. Oh, sorry, it's the best I can do. Why not come back on Monday when I get you a set appointment time with a clinical staff doctor? Because I'm going on a trip and I leave tomorrow. Well, what if I try to get another doctor to speak with you? Well, how long is that going to take? I need to go home and pack. Why can't you just do it? I'm not going to cause trouble for your convenience. Thanks for nothing. And the patient storms out without the paperwork. And of course, everybody in the waiting area of this clinic hears this, which I sometimes call a free show, which is not what the clinic was counting on. But when I do show this to experienced healthcare providers, they all kind of groan in reaction and say, oh my gosh, yes, I had a situation like that just the other day. So what I like to show people is what would have happened if active reflective listening was used instead of how it did play out. So this is from the top again how it would have gone. So let me explain your paperwork and we'll get you on your way. Oh no, I just remembered I forgot to ask the doctor for the chiropractor referral. Why don't you write me up a little note? So instead, if the provider says something like this, so it sounds like you're concerned about pain that wasn't addressed in your visit today, the patient would have said, well, you know what it is? I just found out that I need to fly out to California for my aunt's funeral tomorrow. Last time I sat in those awful airplane seats for 6 hours, I popped out a disc in my lower back. That is the real true life story behind this actual situation in this case. So at which point, when the truth is pulled out, the whole dialogue can shift and then there's going to be no more escalation. The clinician can go into problem-solving mode about a muscle relaxant, depending on what other meds the patient is on, of course, coaching on pre-flight stretches, the possibility of a lumbar pillow. The patient then actually evokes sympathy instead of seeming like a pushy pain in the clinician's butt, right? So this is a real-life case, and the healthcare provider collaborated with me to uncover the story behind the surface story. So this sort of thing always gets great discussion going when we start with a case like this, and we can work into the question of why would you want to bother to improve your listening skills in the first place? And after showing this case to open, one of the first things my participants realize is, boy, that would have saved time. If I realized that the patient wanted perhaps a muscle relaxant or could do with a pillow or some advice, the whole fight wouldn't have happened and I'd be off to just solve the actual problem. The other thing that participants usually say to me is that they realize that if they don't get drawn into these types of encounters all day long, and let's be honest, it's not just patients, it's coworkers, and we'll go into that too. But if they can use these skills to not get drawn in, it's really connected to burnout. And that is something that healthcare providers are facing in a more serious way than they ever have. We'll come back to that in a second. So right away, though, when I work with live audiences, they get it. They just get it that there is something in it for them to be able to master the skills of diffusing these difficult situations. And that is, of course, because they work in a different world. Healthcare, if they trained 30 years ago as a physician or a nurse or so forth, all the different resources that patients avail themselves of just weren't available. A physician friend of mine said to me the other day that he went into a clinical office examining room to see a patient for the first time, had never met them before, made good eye contact, reached out his hand, shook his hand, and before he could say anything, the patient said, "Oh, hi, doc. I looked up what I had in the net, but I came to you for a second opinion." So we've got the role reversal in a lot of ways and a lot of things that people feel like, I didn't go to clinician training for many, many years to face this. Then, of course, there's the whole problem in the United States, and I know in some other countries, where the people do what we call the wallet biopsy first of what is happening with the patient's insurance in relation to what I'm going to be able to offer them. This enrages a lot of clinicians and PAs and nurse practitioners and doctors in terms of the fact that they just can't move past this. And then, of course, we've got the more recent challenges, the frequent media headlines. And here is one where the Surgeon General advisory sounds the alarm on worker burnout and resignation. And in fact, the numbers here are pretty stunning because it indicates that people are just kind of giving up and walking out because of the crisis level problem. 300 million, for example, essential low-wage workers in the next 5 years are projected shortage of 140 physicians by 2033. And again, you'll see the United States Surgeon General is sounding the alarm that this is happening all throughout healthcare. Really great, great challenges everybody's living through. So in this challenging era, everybody's dealing with upset patients. Everybody's dealing with upset coworkers. And sometimes when I work with groups, I say, what does it feel like this upset person really wants from you? And inevitably from the back of the room, somebody will yell out, they want blood. They want something for free. They want me to fix things for them as if I were some sort of magician. And this is what it feels like to healthcare professionals. I've had one healthcare professional said, I feel like a sitting duck in a shooting gallery. And in fact, without the types of skills that I want to talk about today, I'm not surprised that that's exactly what people feel like. Healthcare workers, as we're saying here, often soak up a lot of anger, and anger distorts thinking skills in a tremendous manner. In Boston, Massachusetts, USA, where I live, we are famous for having very bad Boston drivers. And I've read many, many books in human relations and psychology, and many of them talk about the theory that fear triggers anger, and that 99 times out of 100, if somebody's really angry, it's really because they're fearful. And nothing brings this home like a drive in Boston traffic. And down near our area, with those of you who've seen TV, the Cheers bar, down in that area of Boston is very crowded. I remember I was coming off our high-speed highway that runs by the river and taking one of those intersection streets right through that neighborhood. And in Boston, the pedestrians are just as rude as the drivers. And I was coming through that intersection, and there was a traffic light on a little island, and I had the light, so I was going on through. But just as I came through, a single pedestrian walked off that traffic island right in front of my car. And of course, I slammed on the brakes, and I was like, terrified, petrified. I was worried that that person's body was going to flip up on my hood. The second I saw that gentleman was alive, I wanted to kill him. And this is exactly what happens in these emotionally charged healthcare settings. That fear triggers anger, fear triggers anger, fear triggers anger. And again, you go in 1 second, like I did in the car, from, oh my God, I'm going to take human life. I was so scared that I was actually going to hit that person. And then I saw they were alive and walking, and I was like, I want to take a human life. What does this guy think he's doing? So this is a very common, very human phenomena. And we need to remember, to handle the irate person, we got to solve the problem without blaming ourselves too much or them too much. And I see a lot of them blaming in healthcare. When I was allowed to listen in healthcare settings, I used to hear coworkers say to each other, why do all the nasty patients come in on my days working? The really insane, horrible, crazy ones never come in on your days working. All the terrible, terrible, awful patients come in on my days working. And that's what I call playing the victim in relation to patient care. The person's not always right, of course, but they're always an internal or external client of some type. So I teach people to use the active listening response as a tool to diffuse emotionally charged patients and peers. And I spend a lot of time, and this is not what other teachers do and not what other consultants do, but I have found it really useful to teach it by defining it by what it is not. So going back, and we'll come back a few times to the work of Carl Rogers, the father of active listening theory. He wrote originally about a dozen barriers to active reflective listening. And that's just way too many, I find, for learners to pick up quickly. But here they are, just to go over them. And then I'll tell you how I reduce them so that people can pick them up very, very quickly. Ordering. You've got to take this medicine exactly as prescribed or it's not going to work. Warning. If you don't take this prescription like it's, prescribed, that infection's going to come back. Moralizing. You seem so forgetful. You better set your iPhone to remind you of your meds 3 times a day. Advising. I suggest you get your pharmacist to put your meds in a pill organizer. Logic. Too much logic. The fact is that most people forget it most times. Please put a safeguard in place. Criticizing. You're going to be mad at yourself if you just end up back in the hospital. Praising. You're really so very smart to set up that medication reminder system. Labeling. You're being overly worried about your medicines. No need to be so anxious. Analyzing. You're probably just concerned because you've never had to manage a chronic disease before. Reassuring. Look on the bright side. Stabilizing on these meds means you can go home soon. Questioning. Did you talk to your primary doctor about your concerns? And avoiding and diverting. You think you have challenges? I had a patient just last week who had to be discharged on, a dozen medications or something like that. But again, I found that the dozen that Carl Rogers originally wrote about, and I think he was very smart and insightful, but if I just have a little time to work with healthcare professionals, I can't ask them to master a dozen. It's just not realistic. So what I've done is I've sort of compressed the categories into 4, boiled them down to things like, to be empathic, we avoid the basic barriers, and it means not judging, not advising, not quizzing, and not placating. Also, something I learned when I trained to manage group psychotherapy is to think through this person who's currently speaking. Are they mad, sad, glad, or scared? And I realized I could apply this method to healthcare providers who had no background in psychology or interpersonal communication so that they could think more effectively and quickly about what's the emotional match. Let me give you an example. So, for example, one of the most complained about things in healthcare is waiting times, waiting to get an appointment, waiting once you get to the appointment. So that would sound something like this. I keep along, I've been in this clinic, my God, other patients I've saw came in here after me have already been seen by the doctor, and I just can't believe how long this has taken. So obviously, it seems like you're pretty mad because you hadn't found this kind of delay. Yeah, because tell you the truth, if I don't get home soon, my little girl will be there after school all alone. Remember we talked about fear triggering anger? Fear triggering anger. If you match it, they tell you more about what's really going on. Sad. I just came from the doctor and I found out I got to be on this medication the rest of my life. Well, it seems like a pretty sad time for you feeling like it's not going to be like it used to be. Yeah, because what I'm really worried about is, and they could be worried about paying for it. You don't know what they're worried about because you have to hit that first emotion and match it for them to tell you the trigger of what really created the emotional outburst in the first place. Glad. I just came from my doctor. I can't believe, he's gotten way back on my cholesterol meds. Well, seems like pretty glad to get this kind of results. Yeah, that exercise really paid off. And so sometimes you can match what they're saying and find out good triggers too. It's not all bad, although I have to say in healthcare settings, it's probably 3/4 bad news. Scared. I just came from the doctor and I found out that first cancer didn't get all the cancer out. I have to have another cancer surgery. I have to have it by next week. Seems like a pretty scary time to have something like this jump right up on you. Mad, sad, glad, scared, mad, sad, glad, scared, mad, sad, glad, scared. No matter what the patient says to you, you can pick off the list or coworker and flip it back at them and get to the bottom of it. For each one of these, though, think of what I call strong, medium, or mild. So strong would be furious, mad, irritated, devastated, like in a loss of a loved one, sad, maybe just discouraged. See, I'm doing strong, medium, and mild. Glad, ecstatic, glad, relieved. And let's take one for example here. High end of scared would be panicky or desperate. I can't wait to call one more person for authorization. I need to know I'm getting my medication refill now. Seems like you're pretty panicky to get right back on your pills. Yeah, because this isn't the first day I've gone without, and actually I'm feeling kind of sick. They're going to tell you more about what's going on if you match them. Let's take a low level, worried. Are you sure this medication's going to work okay for me? Well, you sound a little worried. Yes, because I was watching a TV information report the other day and I saw how this, medication is for crazy people. And a lot of people do, in fact, mix up the brand names Xanax and Xanax, which is for heartburn medication. So match it and they tell you more, miss it and you never find out. Here's an example of how I really try to help people think about all the ways not to respond. My sister was on these pills. She ain't any better. Why should I think they'll work for me? Well, you're not your sister. You had an entirely different body than hers. And besides, everybody's individual body chemistry is different. You might as well say the word idiot after that sentence. Everybody's body chemistry is different. Idiot. Just 2 weeks advice. Just 2 weeks. Just give the meds a little try. Just 2 weeks and, you'll see you'll be feeling better. In other words, move out of my examining room, idiot. I got to get the next person in here. Quizzing. Did your sister take the medications correctly or is she stupid like you, idiot? Again, they hear the idiot part out loud. You don't even have to say it out loud. They hear it. Placating. Oh, but this is a very good drug. This wasn't even available for patients till last year, so you're really very lucky to get it. You ungrateful idiot. So those are the things not to say, but unfortunately, I've only exaggerated just a little bit. And in the world around us, we hear a lot of judging, advising, and quizzing and placating. And so it's very easy to fall into those patterns. We have to systematically think about what would be the mad, sad, glad, scared response. So here's an example here. So it seems like you're pretty worried because you really need something that's going to help you bounce back quickly. Yeah, because to tell you the truth, my sister didn't start feeling better till she stopped taking these pills all by herself. So match it and you learn so much more about what's going on. Miss it and you never find out. Here's an example of the 5 levels of potential response in relation to the empathic reflective listening. So pretend somebody says to you, this hospital is huge and horrible. I don't know why I got transferred here. My community hospital is right near my house and was so familiar to me and my family. Well, you might be just feeling fussy because you're sick, but you have to remember a large teaching hospital has a lot of more specialists to offer. So it's a combination of what we called placating in the previous slide and judging, advising. Level 2, I can see you're upset, but you'll adjust after a little while. That's placating mostly. Level 3, you're really unhappy with your treatment here. We're getting sort of neutral now. We're breaking even. You're not tossing up as many barriers. Level 4, remember the mad, sad, glad, scared? There it is. So it sounds like you're concerned about your experience here and eager to feel more comfortable about having a real medical home. So we're getting much better. Let's try it really targeted. It's clear you're really unsettled by how different everything is here and how it's not what you expected at all. And it sounds also like this experience at this hospital is making you anxious about what you might have to go through to get good personalized care for yourself. And then don't be surprised if you get an answer that's something like, yeah, I'm so worried. I'm thinking about hiring a private medical advocate like I read about in a newspaper last year. Match it and they tell you more. Miss it by throwing up the obstacles and the barriers, and you will never find out what's really going on with the person. So the next 2 examples show how this works for both coworkers and patients, and then I'll come back to a few more quick examples. Hey, that new electronic record system you want the staff to use hasn't helped at all. In fact, they're screaming about getting more behind than before this supposed improvement was implemented. Well, they could have called the IT folks sooner if they thought they needed help. But they're idiots. Well, next time they shouldn't wait so long before calling for help. But they're idiots. Are they using the system in the way we talked about? I bet not, because they're pretty stupid. Don't worry, I can reassign Jane or John to help them out. That's that placating, pat on the head response. Mad, sad, glad, or scared. What we think is really behind it is concern. So it sounds like you're pretty worried. Things are rapidly getting worse for everyone. No relief in sight. But before we talk about what to do next, tell me what you mean about saying it hasn't helped at all, which in medical terms, that's a triage. And here it is with a patient example. Hey, that junk your people told me to buy at the drugstore last time I came in hasn't helped at all. In fact, I feel sicker than when I first came to ask your advice. See the same dynamics here? You could have called us back sooner if you thought you needed something else, idiot. Next time, don't wait so long before calling back, idiot. Did you use the medicine the way you talked about? I bet you didn't, idiot. Don't worry, at least that product clears your system quickly and we can try something else. Pat, pat, pat on the head. Same thing. Sounds like you're getting pretty worried about those symptoms. Let's try to get to the bottom of it. I'm going to give you 4 quick examples. And remember, we talked about mad, sad, glad, or scared. So I've lined these examples up to go along with the mad, sad, glad, scared sequence. Here's one. I don't know my supervisor. One of he's nice, then he's kind of mean to me. I think I better look for another job. Ironically, we can judge, but think we're standing up for the team and say something like this. Really? I've worked with supervisor X for a good 10 years now here, and you're the first employee ever, ever, ever who's had a problem with him. In other words, it must be you, idiot. Advice, and this is where people give something that they think the other person couldn't have thought through. You should talk to him. You really should talk to him, you unassertive, wimpy moron. Quizzing. What did he say? What did you say? The gossip self can really come out now. And placating. This one's classic, right? Oh, he was just having a bad day. We all have bad days. Mad, sad, glad, or scared. So we're going to go with mad. But I want to warn you, there's an art form to active listening, and you've got to employ it. What if you weren't artful here? What if you said something like this? Sounds like you're mad because he's the same old jerk to you that he is to the rest of us. That's not artful. Take the word mad. I'm going to soften it to irritated, and I'm going to say it in such a way that if this person walks around the corner and hears our whole conversation, I'm still not going to be in trouble. Seems like you're pretty irritated because you're not feeling comfortable with your relationship with him. So Carl Rogers taught that the proper response had the emotional tone, but the words had to be completely fresh. And you notice I've just been changing the words so that they are fresh. Mad, sad. So here we go. My husband's been sick for so long now. I just don't know how much longer I can keep this up. And well-meaning people will say something like this. You shouldn't be trying to handle this all alone, Mrs. So-and-so. As in, again, she couldn't have thought that as an issue. Advice, you need to call the visiting nurses. Quizzing, don't you have any children that can help out? And then she's going to hear that as, I bet your children are bad. I hope they're probably just not helping you because they're bad children. And then placating. And by the way, if you go for a really macabre placation, that's the worst thing of all. And if you say something like, well, it's not going to be much longer now, ma'am. Just horrible. If they say it, then that's a whole different thing. But if you say it first, really wrong. Mad, sad, glad, or scared, it's sad. I'm going to take the sad down to a lower level just in case I'm wrong, so I'm more gentle with it. Boy, this really has gotten discouraging for you, hasn't it? And then if she says, yes, but I know the doctor told me that it'll probably be by the end of the week, then you hear she's working through it. She knows. You're in a whole different situation than if you brought it up. Mad, sad, glad, or scared? Okay, we're on glad. The pharmacist said she thought the medication swap she cleared with my doctor was going to help me, but I can hardly believe how much better I feel after just a few days. Let's cut right to the empathic reflective response. So something in the glad family. I'm going to go with relieved. You know, boy, this has been an amazing relief for you. Yeah, I can actually even feel it when I get up in the morning. I'm just so much less stiff and they're going to tell you more about what exactly happened for them. Mad, sad, glad, and scared. Here's the scared. I waited 3 hours in this ER and I got 3 minutes of time with a nurse. I didn't get a chance to ask all my questions. You just got to get me in to see a real doctor now. Now, see how it seems all angry on the surface? But remember, fear triggers anger. Fear triggers anger. So I'm going to go right down to that reflective response. And by the way, I'm not going to say what I overheard in this actual situation because I told you all my examples are from real life. I actually heard the clinician say to the patient, I happened to look at my watch when you walked in. It has not been 3 hours. It's like throwing lighter fluid right on the flame. Why would you do it? So let's get to the fear that's behind this and say something like, boy, that is concerning. You've been here a long time, and more worrisome, you didn't get an answer to everything you needed to know. And then they're going to say something to you that you never anticipated, like, is it normal to be, oozing blood down the back of my throat when I'm on this medication? Because I just don't think that's normal. It's like, wow, no wonder you're having an emotional outburst. Match it. They tell you more. Miss it. You never find out. After the person is gone, if you had an escalation, it's because you judged, advised, quizzed, or placated. There's just no other reason. If you came back with pure active listening, there is no escalation. So if there was an escalation to some sort of something that sounded like a conflict, you played into it. So think about that as your lasting legacy with patients and peers, or how I put it, what do they say about you over coffee at the Starbucks in the hospital lobby? That's a very good bottom line question, because they're probably not going to say, yeah, that surgeon had the most amazing skill with my new titanium hips. They're going to talk about how you talk to them or how you talk to their loved ones. So I got asked the other question for this presentation, which is, a little bit about my background to help answer the question about why do I think this method of teaching that I've been doing for many years now with a wide variety of organizations, like, why does it work? A little bit more background maybe than you bargained on, but I want to say from the heart that I see myself as a humanist. And humanists think that people are good at heart and capable of making the right choices for themselves. So people trained in humanistic therapy, as I was, we believe that the clients are the best problem solvers for their own selves. So notice how I was always saying, match it and they'll tell you more. So they're getting at what it is that they need to think through and solve. In my 20s, I was trained as a psychotherapist by a clinician who himself was trained by Carl Rogers. So this approach, again, is considered to be the main type of humanistic therapy. It's based on the idea that absorbing criticism or disapproval from others can distort our self-concept and ability to self-direct. There's the key part, ability to self-direct. Here's a more recent reprint of Rogers' work if you want to look it up. My mentor, Kiyo Morimoto, was the director of college student counseling at Harvard University for almost 3 decades. His adherence to Rogers' philosophy created a gently hospitable environment where students were able to unburden themselves of fears, insecurities, and other self-defeating thoughts so that they could free up their energy for what they needed to do. Again, I think it's worth mentioning that I was trained before the extensive privacy medical laws were put into place, and I was thereby allowed to record all my client psychotherapy sessions. And they were tapes in those days. And I took the tapes to my clinical supervisor, who had his hand on the stop playback button to examine each and every utterance I made to determine that I had the ability to match my client in a pure Rogerian style. Here's a quote by my mentor, Kiyo Morimoto. One of the most difficult things to learn is to listen, in some ways see the world as the other person sees it, not just conceptually, but also experientially and emotionally. It has always bothered me to presume that anyone can put themselves in the position of the other person completely. What I try to do is listen as totally as I can to what the individual is saying and recognize each of his feelings experientially with him, without placing any priority on one or the other, but knowing that every one of his feelings, no matter how contradictory or how far out or how shameful, is legitimate because he feels it. Until he's been heard in this way and knows somehow that he's been heard, he'll be reluctant to share openly. Match it, and they tell you more. Avoid the barriers. Again, the heritage of these ideas is clear. Here's Carl Rogers. I'm trying to determine whether my understanding of the client's inner world is correct, whether I'm seeing it as he or she is experiencing it in the moment. Each response of mine contains the unspoken question: is this the way it is for you? Am I catching the color and texture and flavor of the personal meaning you're experiencing right now? And over 3 decades ago, I realized that healthcare professionals would be vitally interested in learning these counseling skills. And that's why I have been spending so much time devoted to creating examples to help them learn that. One of the biggest criticisms of Carl Rogers is that you sound like a parrot or echoing, and he recognized that. He said, although I'm partially responsible for the use of this term to describe a certain type of therapist response, I've over the years become really unhappy with it. And a major reason is that reflection of feelings has not infrequently been taught as a technique, and sometimes a very wooden technique at that. And on the basis of written client expressions, the learner is expected to concoct a correct reflection of feeling, or even worse, to select the correct response from a multiple choice list. Such training has little to do with an effective therapeutic relationship, so I've become more and more allergic to the use of the term. So Carl Rogers, the year before his death, right there is saying clearly he knew that many people mangled his methodology. They did not learn it at the level of refinement that he intended. And yet, to this day, it is the method that is taught to people that is most successful in helping suicidal people not to commit suicide. And that makes sense to me, because the world is where you're going to be able to come back and solve your own problems. If you have somebody who's trying to give you a bunch of advice as some sort of therapeutic technique or one of the other barriers, as a suicidal person, you're going to feel like the world's just not hospitable. Why should I hang around? The world isn't good for me. So today I shared with you examples of training materials that I've developed over these decades. The interest is enduring. It never goes away. Sometimes it gets new catch names or new phrases or new titles, but it's basically still what people are interested in, the human relations connection. Here's a list of some organizations I've worked with: the American Association of Physician Leadership. I've worked with the American Association of Physician Executives, oncology societies, pharmaceutical businesses, pharmacy societies, hospitals like those in New York and different large urban areas, sometimes medical communication companies, and a lot of work lately with oncology. But I've been very happy. I've been able to work all over the United States and to work in a lot of different countries. And I am always reminded of the phrase, why am I considered to have any expertise in this? There's the old expression: anybody who's more than 150 miles from home with a PowerPoint presentation. And many days that did describe me. So recap that question asked of me. Why do I spend so much time teaching the non-empathic ways to respond when listening? It seems counterintuitive. The reason I believe this has worked is because we all share this common humanity. We all recognize pretty quickly that we tend to judge, advise, quiz, and placate. Since childhood, we've heard all the people around us and in the media creating these verbal obstacles. And by practicing these barriers out loud, even though it seems weird, with real-life examples, we learn to catch ourselves as we hear ourselves and thereby stop formulating the barriers. This leaves more opportunity to produce the inherently useful, reflective, active listening responses. Let me just give you one example from childhood. Typical parent-child fight. Let's make it a mother-child. And the mother says to the child, I can't believe that room. That room is a mess. That room is a pigsty. I must have asked you 10 times this week to clean up that room. And little kids learn to listen to TV. They listen to their older siblings. They listen to, they listen to kids at school. So they learn to come back at their mother at a certain age. And often they'll come back with a quiz and they'll say something like this. I bet you didn't keep your room totally clean when you were a kid. Right, Mom? Here's a quiz. And now Mom's going to come down with a judgmental hammer. What does that have to do with this? That has nothing to do with this. I've told you 10 times to clean that room. Whose mom said, Mad, Sad, Glad, Scared? Sounds like you're kind of mad because you feel like I'm holding you to standards that maybe I wasn't held to myself. I'm quite certain your mom said nothing like that. And I know my mom said nothing like that. TV, school, the family, and now streaming content has systematically taught us all the barriers to active reflective listening. And instead, what I'm asking us is to remind ourselves what they are so we can catch them before they come out of our mouths. Hopefully someday in this COVID era, we can have a good mutual conversation and discussion. And until then, please feel free to reach out to me. This has been such an honor to be asked by the Global Listening Center to address you all in this year 2022 as we're coming through very tough COVID times. I appreciate this, and again, would look forward to sharing the same air and talking to you someday. Thank you so much.